To Christian Medical Lab. Today we are going to discuss about the multiple myeloma. So we will start with the definition. It is defined by combination of plasma cell myeloma, usually associated with a serum and or urine monoclonal immunoglobulin, and either evidence of organ damage related to disease or in the absence of organ damage, laboratory or imaging findings that suggest high risk of developing end organ damage within 2 years. Group is 66 to 70 years old. Slightly more common in male population, ratio is 1.4 to 1. City more common in western population and African population. Low in Asian population. Are at risk. The person with autoimmune disorders, because there is a constant B cell activation. Farmers, because they are associated with pesticides. Woodworkers and petrochemical workers, because of benzene. Also, there is a radiation hazard. We are going toward the integrated pathophysiology. So, what is integrated pathophysiology? So, here I will include all etiology with the pathophysiology, with the clinical features, and the investigation parts. Everything in one process, in a flow. You don't have to read everything separately when you can combine everything in one way. So let's get started with the integrated pathophysiology of multiple myeloma. So everything start from your bone marrow. So this is your bone. Okay, this is your bone, and this is a bone marrow. In this bone marrow, you will find hematopoietic stem cell. These hematopoietic stem cell produce common lymphocyte progenitor. This common lymphocyte progenitor will produce pro B cell, then pre B cell. This will produce your immature B cell, then mature B cell, which is a naive B cell, which is naive B cell. Now this mature B cell will go to your lymph node. Where? Your lymph node. Bone marrow to lymph node. So lymph node is like this. They will make aggregates, making follicles, and this is called the primary follicles. Okay. So this is a follicular area. This one is a follicular area, and other than this, parafollicular area. So in parafollicular area, there are T cells, and these T cells are coming from your entire body. They are getting activated by the antigen presenting cells, by the external antigen or internal antigen, and then they will activate your B cell, which are the naive B cell. Here only they will activate your B cell at this interface. So these are the T cell, and these B cells are getting activated. Now these activated B cell, also called immunoblast, will convert into the centroblast. At the center of the follicle, they will migrate to the center of the follicle and make the secondary follicle. Okay, this follicle is primary follicle. This one is the primary follicle. Now it will form the secondary follicles like this. So center is a germinal center, and the outer is the mantle zone or marginal zone. So this centroblast will produce centrocyte, and after that this centrocyte will produce your plasma blast, or it can produce a memory B cell also. So during this process, activated B cells to the plasma blast, certain mechanism which help this process, this entire process. First one is the somatic hypermutation. They will lose the CD19, CD20 receptor molecule, so that plasma cells is devoid of these common B cell markers like 19 and 20. Then another mechanism is a class switch recombination. During this somatic hypermutation and class switching recombination, there are certain molecular change and your plasma blast is now ready. And this plasma blast will go to your mucosa. It will short live there. It will go to your bone marrow. And bone marrow will help to survive this plasma blast by the IL-6, April, and VEGF like factors. Okay, and it will be a long-lived plasma cell, and it will produce antibodies against the specific antigen. So this is the normal process. But what happen in multiple myeloma, you have to understand this mechanism. So activated B lymphocyte, this activated B lymphocyte, when it convert into the plasma blast, there is some mutations. This class switch recombination and somatic hypermutation process, one of your DNA will break down from IGH locus at chromosome number 14q32. At this place, your chromosome will detach. It will detach like this, and it will bind to the chromosome number 4, 11, 18, and 20. It will bind to these four type of chromosome and make translocation mutation. So it would be translocation for 14, translocation for 11 14, translocation 14 18, location 14 20. Okay, so this type of translocations will cause this normal plasma blast into the mutated plasma blast, and these plasma blasts now go to your bone marrow, and they will reside there silently. They will act, they will produce immunoglobulins and proteins, and this will cause MGUS, monoclonal gammopathy of undetermined significance. This is one condition. In here, you will not see any symptoms, not see any myeloma defining events, just you will see the M protein, which is a less than gram per deciliter of your M protein. So nothing to worry about this condition, but if you can diagnose this condition, it is a very beneficial for patient, because we can stop this clone from growing towards the multiple myeloma. Mutation is not enough for the multiple myeloma. So next, this plasma blast will get hyperdiploidy of odd numbers chromosomes. Okay, 3 5 7 9 11 13 15 19 21. Now the smoldering myeloma, in which you will get more than 10% of clonal plasma cells in bone marrow, but not more than 60%, not more than 60%. This is the criteria, and you are not seeing any myeloma specific symptoms or myeloma defining events. All are absent, just increased plasma cells you will see. This is also not enough for causing multiple myeloma, so that your body will produce some type of mutations in this plasma blast, which is in the smoldering myeloma phase, and this mutation is TP53 deletion MIC rearrangement, and epigenetic drift by set to overexpression. These will lead to your multiple myeloma. Multiple myeloma. So, what is the criteria? More than 10% of the clonal plasma cell in bone marrow with myeloma defining event. Myeloma defining event. So, one of the myeloma defining event. The total 4 myeloma defining events are there. I will explain everything in the next phase. Now, you are understanding that how this plasma blast is mutated and how the process come from the gammopathy of undetermined significance to smoldering myeloma to the multiple myeloma. You are now understood everything about the genetic process. These plasma cells look like. How these plasma cells look like. So plasma cells having the round to oval shape, basophilic cytoplasm, perinuclear half due to the Golgi apparatus, then the round acentric nuclei with the clock face chromatin. Okay, so variants are the plant cells and also two bodies, Russell body and Dutcher body. You will see. First of all, these plasma cells are producing some kind of monoclonal immunoglobulin. Okay, so also called as a M protein. Next, it will produce your free light chain. Free light chain. Third thing are the cytokines like IL-6, also VEGF. Then it is producing the MIP1 alpha, rank L. Also, it will produce your DKK1 and beta 2 microglobulin. Understood? We are going to discuss about these secretory products and what it causes, how it produces symptoms, and how can you detect these products. So first one is your monoclonal immunoglobulin M protein. So M protein. So basically, these are the specific immunoglobulins. Either it would be IgG, then IgA, then IgD, then IgM. So most common is IgG. So most common 60% of multiple myeloma release the IgG monoclonal immunoglobulin. Okay. So what will happen? Blood will have so much of immunoglobulin which is IgG. Now this will cause increase the density of your blood. So it is called the blood viscosity. It is increasing your blood viscosity. So due to blood viscosity, you will get headache, blurry vision, and dizziness. This is due to the increased blood viscosity. This is due to increased blood viscosity. Now this increased monoclonal protein will increase surface charge of RBC. They will stuck around the RBC and RBC will get stuck, and this is called the rouleau formation. And this rouleau formation will eventually increase your erythrocyte sedimentation rate. Next thing, it can cause your suppression of the immunity. How? These are not specific antibodies. not specific immunoglobulins against the specific targets like microorganism or the external antigen, but these are the random non-specific antibodies. That opsonization process is completely nullified, and your immunity is not enough to kill that bacteria. You are at the risk of repeated infections. Common cause of death in multiple myeloma, repeated infections. You have to find out that this patient having the monoclonal antibodies, monoclonal immunoglobulins. So how will you assess that? First one is the serum protein electrophoresis. Also, you can do the urine protein electrophoresis, serum or urine protein electrophoresis. Second, you can do serum immunofixative electrophoresis. Here you just see the M protein is there. By this test, you will see that, oh, M protein is there, but which M protein, which immunoglobulin? So it is IgG or IgA. You will know the specific type of immunoglobulin in this method. So these two tests we are performing for the detection of the M protein. And here in the serum protein electrophoresis, you will see the graph like this, M spike. Next is your free light chain. So these plasma cells are not just creating immunoglobulins, they are making more light chain than the heavy chains. So this free light chain will goes into your kidney, and they will stuck into the lumen of the tubules, and these tubules are now damaged by these antibodies, means the immunoglobulins, and it is causing the cast nephropathy. So your creatinine value will be increased more than 2 milligram per deciliter. Okay, so this is causing the renal impairment. Okay, renal impairment. Patients now stuck at the glomeruli or heart or liver, and this will cause amyloid light chain type amyloidosis, AL type amyloidosis. So you will see the Benz-John proteinuria. So ultimately, you will see the uremic symptoms. Uremic symptoms. Free light chain is the main myeloma defining event. So we have to use pre light chain assay, free light chain assay, FLCA. This we are measuring the involved light chain by uninvolved light chain ratio. So if your kappa is involved in these multiple myeloma, so it is around the 320, or this uninvolved is a 10, just lambda which is 10, then this is a monoclonal kappa restricted. So this ratio is more than or 100. Okay, more than or 100, so milligram per deciliter. This is the ratio. If you find this, then it is a myeloma defining event. You don't need anything else, no symptoms at all, just this is the enough for the diagnosis of the multiple myeloma. I will explain this later. Secretory products are the IL-6 and VEGF. So IL-6, why IL-6 is so important for the plasma cell? Because it helps them to survive and proliferate. This is the only molecule which is helping the plasma cells very nicely. So IL-6 they need for the survival and proliferation. Also, it will activate your hepcidin. Hepcidin. And hepcidin is a ion checkpoint regulator. So it will, this activated hepcidin will block your ion absorption from your cells into the blood. So your iron absorption is nullified and you will develop the anemia. Okay, so anemia is not just due to the abscindine activation, but also these plasma cells which are the infiltrating your bone marrow like this nodular pattern, interstitial pattern, or diffuse sheet like pattern. They will not give any space for erythropoiesis. So how can your body can synthesize RBCs? So there are no RBCs, and this will lead to the anemia, severe anemia. TAP is nothing but a factor for the angiogenesis. So blood is food and they will create pathway to get blood. So VEGF helping plasma cells. Most important, MIP1 alpha and RANKL. So MIP1 alpha is the macrophage inflammatory protein 1 alpha and RANKL is a receptor activation of nuclear factor kappa beta ligand. They will activate your osteoclast. What? Osteoclast. These are the bone eaters and they will destroy your bone, so it will create the punch out lesions on bone. You will find it on MRI. Okay, if the lesions are more than or equal more than one, if you find a lesion more than one and any lesion which is more than 0.5 centimeter or 5 mm, it is a myeloma defining events. Okay, it is one of the myeloma defining events. Punch out lesion you will do MRI. So radiology you will see punch out lesions. Now your bones are destroying, so bone containing the which minerals? Calcium. So your calcium will come into your blood and it will cause the hypercalcemia. Hypercalcemia, and this hypercalcemia cause constipation, muscle overtone, psychiatric overtone, and your skeletal musculoskeletal abnormality or muscle weakness, nausea, vomiting, dizziness, everything is related to the hypercalcemia. Also it will cause your nephrolithiasis. Okay, so additional renal damage is occurred due to the hypercalcemia. This is a DKK1, this is a DKOF1, it will inhibit your osteoblast so that your bone formation is completely shut down. And beta 2 microglobulin, this is the most important because clinicians are using this beta 2 microglobulin for the assessment of the tumor burden. If this level beta 2 microglobulin level is so high, then it is predicted that it is a pure prognosis. Pathologist and radiologist will make a diagnosis by the combining all features. So first one is the MGUS, means the monoclonal gammopathy of undetermined significance. Here you just see the M protein which is a less than 3 per deciliter, just only this feature without crab feature. What is crab feature? I will explain you. Crab feature or myeloma defining event absent. Okay. Smoldering myeloma. You need M protein more than or equal to 3 gram per deciliter. Also, you need bone marrow biopsy, and here you will find the more than or equal to 10% clonal plasma cells. How will you explain that this is a clonal or not clonal? So by the ISC, kappa and lambda ISCs. So most of cells, most of means 100% of cells are kappa restricted, only kappa positive, not lambda positive. Okay, if 50% of cells are kappa positive and 50% cells are lambda positive, then it is a not a clonal plasma cell. Okay, bro. So you will find more than or equal to 10% clonal plasma cells in bone marrow. This is the first criteria. Also, myeloma defining event should be absent throughout. So this clonal plasma cell should less than 60%, should less than 60%. So that multiple myeloma, here you will see more than 10% of the plasma cells, clonal plasma cell in bone marrow. Second, you will see the M protein is more than 3 gram per deciliter, plus any one of these myeloma defining events. So myeloma defining events are the false. Total 4 myeloma defining events. First one is the CRAB criteria. So that your hypercalcemia, so your calcium level should be more than 11 milligram per deciliter. For renal impairment. So here your creatinine level, serum creatinine level should be more than 2 milligram per deciliter. A for anemia. So your HB should be less than 10 gram per deciliter. And B for bone lesion. So on MRI you will see the punch out lesion irrelevant of the size, punch out lesions. So this is a CRAB criteria. All four symptoms are present, then it is the myeloma defining event. Okay. Now, second myeloma defining event is the bone marrow finding. If you find more than or equal to 60% of the clonal plasma cells, then it is called as the myeloma defining event. You don't need this type of CRAB features to call multiple myeloma. Third myeloma defining event is your serum free light chain assay. In this, involved light chain are more than 100 gram per liter. 100 milligram per liter. Last myeloma defining event is your punch out bone lesion on MRI scan, and here it should be more than one lesion and it should be more than 5 in size. Okay. In this, the common criteria is the more than 10% of clonal plasma cell in bone marrow. So bone marrow biopsy is a must for this. Mutations are also predicting the prognosis based on the beta 2 microglobulin, and also on serum albumin or cytogenetics. So there are 1, 2, 3 type. So beta 2 microglobulin levels should be less than 3.5 milligram per liter, then 3.5 to 5.5, then more than 5.5 milligram per liter, and albumin level is different, and the cytogenetics are heavily involved, then it is a type 3. So in this stage 3, the prognosis is very poor and only 3-year median overall survival is there in the stage 3. So this is used by the clinician. Best treatment is autologous stem cell transplant. So what is this? If I have multiple myeloma, first do the induction therapy. First kill all plasma cells. I will take out the bone marrow from my body, filter out all non-hematopoietic stem cells, which are the CD34 negative. Okay. And then they will make the solution which is only having the stem cells, hematopoietic stem cells. Then they will give me the melphalan myeloablative agent, so that all hematopoietic stem cells or all hematopoietic cells in my body will be destroyed. by these myeloablative agents. After that, they will insert the bone marrow, which is made from the solution only having the hematopoietic stem cell. They will insert into my medial cubital vein just like an injection. Okay, and this will go to my bone marrow. They will settle down there and they will proliferate, and the entire new system is created. Hematopoietic stem cells making the all new RBC, new WBC, platelet, everything will be a new. For that, you have to also measure the minimal disease, minimal residual disease, MRD. So each is a very important. You can assess it by the PCR or next generation sequencing. Everything you can use, and it should be very low, 0.0001. But this, even one single plasmablast or plasma cell is there in your body, then it will cause relapse, and the relapse, you have to do entire thing again. So this is about the autologous stem cell transplant. Other therapy is the proteasome inhibitors. So proteasome. So these plasma cells are making so much of immunoglobulin. So sometimes they produce a misfolded protein by mistake. So they have to clear it out. Otherwise, it will increase their endoplasmic retinaculum stress, ER stress, and this will lead to the apoptosis if not cleared. So that we are giving 26 subunit of the proteasome inhibitor, and here bortezomib, and this drug will cause the obstruction at the proteasome level, so no misfolded protein will get clear, and here this will cause the apoptosis of the plasma cells and they will die by this drug. Okay, the best drug. Third, you can give the immunomodulator. They will inhibit the production of the transcription factors, which lead to the production of the these plasma cells. And also we have lenalidomide like drug. Here's a bortezomib. Fourth, corticosteroids. Here we have the prednisolone or dexamethasone, and they will inhibit the process of the multiplying process, antigenic stimulation, also decrease your immunity. Fifth, you can give the monoclonal antibodies like anti-CD38, also called the anti-syndecan 1. Okay, so daratumab also you can give. Also, you can go for the CAR T cell therapy. CAR T cell therapy. You are giving thumbs up to this video and share with this video friends. Thank you so much for watching entire video. Thank you so much.